you are actively draining from the left chambers, essentially you're creating like a closed loop circuit of the same blood that you're recirculating. You have this, you should see how powerful that is.
Okay, guys. Andrei Pop here on behalf of MurmurMD. Delighted to have Dr. Gennaro Giustino from Morristown Medical Center. He is an expert operator in many fields, including structural, and he has a lot of experience with ECMO as well. And he wanted to share a case of LAVA ECMO. So, Gennaro, take it away.
Yeah, Andrei, thank you so much for having me and contributing to the great community of MurmurMD. So I'm going to be talking about specifically LAVA ECMO in the setting of structural heart disease, which I think is like is a very helpful tool, particularly in very sick patients that either presenting shock or what I call it at risk for shock. And I'm really passionate about this field because I think it's an emerging reality is that there is an intersection between structural heart and cardiogenic shock management in the sense like structural heart people usually they're like facile with delivery of structural heart therapies and large bore access. And at the same time, a good proportion of patients that present with cardiogenic shock, they are not purely MI-related cardiogenic shock, but actually they are a mixture of valvular shock and other like what I call it structural shock. This was recently seen as a show very nicely in by the Cleveland Clinic in this series, looking at patients with valvular cardiogenic shock (VCS). About 16% of this very large group of patients had what it was called valvular shock for a variety of reasons, mostly regurgitant or stenotic lesions, and was shown that they had a higher mortality compared to non-valvular related cardiogenic shock. However, if these patients had to undergo treatment with percutaneous therapy or with surgery, they actually had much higher chances of survival, as you can imagine. So what are the options for mechanical cardiocirculatory in cardiogenic shock? So they're kind of a problem because, as you guys know, if someone, for example, has severe AI, impeller or a balloon pump would be contraindicated or ineffective. So structural heart disease kind of like complicates the decision on what mechanical cardiocirculatory support device to use. And we all know from ECMO, regular ECMO, VNRT ECMO, that it provides cardiocirculatory support and oxygenation. However, it increases afterload and therefore increases myocardial oxygen demand. And over time, this can result in increasing the diastolic pressure and pulmonary wedge pressure and pulmonary edema and stuff like that. So that's why we do unloading. And when we do unloading, most of the people would just like put an impeller or put a balloon pump. However, if you perform what is called transeptal cannulation, that you put the venous canal directly transeptal into the left atrium, then you can provide full cardiocirculatory support with concomitant left ventricular unloading. I'm going to show a little bit of data, and then I'm going to deep dive into cases and clinical application. This is from our registry at Henry Ford, which is the largest LAVA ECMO registry out there. Essentially, we show that regardless of the etiology of shock, ischemic or non-ischemic, LAVA consistently reduced PA pressure, wedge pressure, left ventricular and diastolic pressure increase, and increase cardiac output. There is also a randomized trial out there done in Korea, very small, about like 100 patients, where patients that were placed on VA ECMO were randomized to switching to transeptal venous cannulation to LAVA versus just conventional therapy. And it showed that the rate of incidence of death or rescue cannulation or addition of another device for LV unloading was much lower with the strategy of LAVA. And very interesting, also the rate of disappearance of pulmonary edema was much faster with LAVA. And this is why, now I get into the valvular part, is why I think this strategy is really helpful in the valvular shock settings, because it provides all of these advantages and essentially makes the type of lesion of valvular lesion on the left side kind of irrelevant. So this is a series that I look into LAVA ECMO in valvular cardiogenic shock, again, from a variety of reasons, mostly aortic valve and mitral valve, mostly regurgitation lesions. So you would think that ECMO itself should not be used. And instead, regardless of the etiology, LAVA was consistently associated with reduction in pulmonary pressure, wedge pressure, and diastolic pressure across all type of valvular lesion. Specifically, we look at all these markers in the acute aortic regurgitation setting, and this served as a bridge to surgery or transcatheter therapy in order to stabilize the patient, unload the lungs, allow for end organ recovery, and then go from there. Another interesting series that we've been looking at is the post-MI VSDs. As you guys know, post-MI VSD are very challenging because they both increase in volume overload of both ventricles, and these patients can develop very quickly biventricular failure and refractory pulmonary edema. In this setting, LAVA is good because provides active biventricular unloading and avoids to put another device in the left ventricle. And in this series of only 5 patients, we were able to essentially, with a strategy of put the patient on LAVA, let it cool off, and then go for surgery or transcatheter therapy. 5 out of 5 cases were made it to that, and 4 out of 5 were decannulated and 1 died. So what are how to do this? So you can do this either with transesophageal echo or with ICE guidance. If you want to do an awake cannulation, this is totally possible. You just advance the ICE in the right atrium, visualize the fossa, and you go for a mid puncture. I do this with the VersaCross wire. So essentially, I just send the VersaCross in the left upper pulmonary vein for the transeptal, and then that's it. You can do a septostomy like a 10 millimeter balloon, and then you can advance the cannula over the wire and telescoping with the dilator in the left upper pulmonary vein. Usually it's better to do directly in the left upper pulmonary vein since it provides better anchoring and the cannula is not being hanging in the left atrium. It gives much more stability and is much less likely to migrate from the LA into the array. That was just a transeptal puncture. You would send the left upper pulmonary vein in the wire in the left upper pulmonary vein, and then send the cannula over the wire, telescoping over the dilator in the left upper pulmonary vein.
So you actually keep the cannula in the left upper pulmonary vein?
That's what I do, yes. So the sign is that after you cross, you send the wire in the left upper pulmonary vein, and the sign is that the wire goes beyond the cardiac silhouette, and you're there. You're not in the appendage. This is if you don't have.
If it's beyond the cardiac silhouette and the patient is alive, then you're probably in the left upper pulmonary vein.
Most likely, yes.
Yeah. So just curious, what cannula do you use?
I usually use a 23 French multi-stage fenestrated cannula. So you can the one I use the most is the Medtronic Biomedicus. You can do this with the LivaNova as well. Not sure if there are other multi-stage fenestrated cannula, but essentially the point is that the cannula needs to have a set of fenestration that are going to be sitting both on the left side of the heart and on the right side of the heart. So you're actively draining blood from the left atrium, the right atrium, and the inferior vena cava.
And that ensures that you're not getting suction from the pulmonary vein.
Yes, exactly, because you have the holes around the cannula. Anecdotally, I have seen suctioning more frequently happening if the cannula is not in the pulmonary vein, it's actually in the left atrium. Then the tip of the cannula was suck against the wall. If the cannula is sitting in the pulmonary vein, I haven't had issues. And in terms of arterial cannula, depends on the body size as usual. So if I'm using LAVA for preventive, like in high risk towers and stuff like that, then I just use a 15 French cannula. If it is for true cardiogenic shock, then I usually go with the 17, so you can provide more flow, as you know. Any questions?
So you're doing this ad hoc, right? Does your cath lab team have the skills to put people on ECMO, or do you rely on our staff?
No, I just need a perfusionist. That's it.
Okay.
And I do both. I do either emergent cannulation or ad hoc for like high risk, what I call high risk tower. But I do this in the cath lab very easily. I mean, it's just like a big cannula, not much.
And under the VSD cases,
Yeah.
do you keep them on ECMO for a few more days after repair? Because a lot of times the VSDs, you put a device in and it embolizes, or the defect gets bigger and bad things happen.
So not only those cases, but also patients that are very decompensated. Show some case example that are like very decompensated. I don't know, diuresis more aggressively. I wanna continue provide better kidney unloading and stuff like that. So yeah, I keep the patient on LAVA, and then I decannulate them a few days later. Sometimes the congestion can be pretty dramatic. Patients like get off ventilator because they get diuresis so quickly, because essentially you have a patient on ECMO with like a wedge pressure of like 10. So that's a big advantage. And for VSDs, what you do, you put them on LAVA, let them cool off, can get a CT, do your planning, and then decide surgery or transcatheter. Then you can do it, and then you can keep them or decannulate at the end. Up to you.
Awesome.
All right, so this is an example. I'm gonna do some example in the aortic, the mitral, VSDs, and stuff like that. So this is a patient with 73-year-old previous AVR, Magna 25, presents with critical AS and shock and new severe LV dysfunction. So he comes over the weekend. So first what I did in this case was putting the LAVA. So the patient was in a biventricular failure, pulmonary hypertension with a bioprosthetic valve, critically stenosis, with an AKI. So I put the patient on LAVA, stabilize, patient got better, then I get a CT, I get the plan. Looks like it has a high risk for occlusion of the left main, as you can appreciate. So I planned for unicorn and on LAVA ECMO support. So you can see here the LAVA cannula in place, MurmurMD valve, traversal of the leaflet as usual. Usual unicorn, nothing different. In this case, I completely destroyed the leaflet with a 16 valvuloplasty balloon. So now the patient has severe AI and remains completely stable despite that, since the patient is on ECMO anyways. So then put the valve, good result. So in this specific case, yes, I kept the patient on LAVA. I make sure that the pulmonary pressure, the ventricle got better, and then I decannulated the patient.
Yeah, I think the AI cases are so satisfying, because once you replace their valve, they start diuresing, and you can remove 10 liters in a couple of days, and they get so much better, so much quicker.
Yeah. So this one present with critical AS.
Okay.
So acute severe AI. I think if you have a sense of what valve to put, then you can avoid this and don't rush. But critical AS, particularly if you have coronary obstruction issue and stuff like that, I think stabilize first, and then get a plan, no rush, and then do it on support. I think it's you avoid getting in trouble for going fast.
Yeah, it's kind of like Impella for high risk PCI.
Exactly, it's the same extrapolated concept. Another case. So this is I did recently. Patient with had a flail cusp on the non-coronary side and had stenosis of the left and the right. They presented like super decompensated. Again, you can see both coronaries at risk. The right very low, very close to the frame. The VTSTJ pretty tight. So, anyways, I planned for bilateral unicorn. So here you can see I'm doing septostomy. Here I'm cannulating. That's the baseline aortogram. Quarter eye super close. So I traverse the leaflet, balloon. Here you can see the access point. I have the venous cannula on the right side. Usually transeptal cannulations are easier from the right than from the left, but you can do that from the left too. And then I have a 15 French RTL cannula on the left. I have the tubing under the drape, so it doesn't interfere with you working. Here I have a 22 dry seal, and I have now a valvuloplasty balloon and a guide, an 8 French guide for traversal of the left leaflet. Usual Unicor stuff. So now I have 2 valvuloplasty balloon across the leaflets, and I inflate these sequentially. One for the left. Again, for complete destruction of the leaflet, I think in the evolutes is better than interleaflet deployment. And then this is what you have after. You have complete wide open AI, and believe it or not, like patient is completely rock stable on LAVA. Then I go for the implantation. Again, the patient is allowed. You can do like very long pacing. Doesn't matter. What you see is that the pulsatility goes down. To take a video of that at a certain point. And then, but the map stays high. And then at the second you stop pacing after you implant the valve, the pulsatility like comes back almost right away. And that was the final result. And this patient had a cannulated at the end. It was she was very stable after the valve went in. Another interesting case. This is a case we published a couple of years ago. This is a patient that 70-year-old woman, prior SAVR and surgical mitral valve replacement that presents with severe AI and severe MS with an EF of 15%. Super decompensated again. We put the patient on LAVA. You can see the hemodynamic effect already. Pulmonary pressure goes from 60 to 30, wedge from 36 to nothing. And then we stabilize the patient. We wait for recovery. She was in a Florida AKI, diarester. We got a CT. And then we planned for a simultaneous valve-in-valve of the aortic valve and the mitral valve. So this is the case. You can see all the access point, sentinel here, pictured on the left radial. Here is the venous cannula in the right groin, and the arterial cannula. Here you have 2 E-sheaths, one for the TAVR and one for the TMVR, each one pre-closed. Crossing fracture valve in the aorta, and then after that we put back the venous cannula from the left atrium in the IVC, recross, and then we did the mitral valve in valve, and this patient was decannulated at the end of the case, and she made it out of the hospital. Another case in mitral, which I did the opposite. This was a good case of very interesting of a patient that had robotic mitral valve repair at another hospital with an incomplete band and an Alfieri stitch, and that's severe and comes first with progression of moderate AS to severe AS. Then I put a core valve, an evolute, and then she still has torrential MR with severe pulmonary hypertension, like a pulmonary pressure in the 70s, and RV dysfunction with cardiogenic cirrhosis. So essentially, I do like an antegrade the lampoon and elastic at the same time. I lacerate the anterior mitral leaflet and the Alfieri stitch, and then I put the valve. I did this whole case on ECMO because my rationale was that after you lacerate the stitch and you lacerate the valve with a pulmonary pressure baseline of 70, the patient can go into hemodynamic collapse. And also I want to have like a very long rapid pacing to nail the incomplete band. The video is not going. Anyways. So at the end of this case, I actually switch to LAVA. So the valve got in, then I use the defect to put with a change cannula and put the patient on LAVA, and then keep the patient on LAVA for a couple of days to the ARES to wait for the pulmonary pressure to come down, and that finally happened. And then at the end, I did this thing, and then I closed the iatrogenic ASD because the patient also had pretty significant TR to avoid hypoxemia. This is something I do when I when I decannulate and I know that I need to close the ASD. So essentially I close it from the cannula itself. So what I do, I puncture the back of the cannula with a quick needle. I make like a little cut with a blade. Then I send a wire in the LA through the cannula after I clamp the back. So the patient is not on ECMO anymore. And then I send a sheath, and then I essentially deploy the ASD on the way out. So you don't need to get further access and stuff like that. You can just like come out with that. I always say that if the surgeons call you to ask for help, it must be that you're doing something right. But anyways, this was a patient that had a Bental, and a few days later, rest in hospital, and with polymorphic VT, he had an EF of like 15% at that point, completely down, and had a critical occlusion of the left main. So I put the patient on LAVA since I didn't want to put anything across the Bental, and also he was like too in shock for Impella. People would not have touched him. So anyways, I put the first on LAVA. This shows critical status of the button, and then I did the left main PCI on LAVA support, and then at the end, the cannulate. The cannulate days later. Yeah, those are were other cases, but like two other crazy stuff. A couple of things about like how to implement this in the practice. I don't know. I think this is something like we are still working, because I'm sure you guys have shock teams, but having this type of like expertise and skill set on the team, I think is valuable, and it's important that everybody understands the the pros and cons of using a strategy of LAVA ECMO versus using a strategy of VA ECMO, then an Impella, or understanding what's the structural heart situation of an individual patient, if there is concomitant valve disease, what's the primary etiology of the shock and stuff like that. So it's important in these specific cases. We are, as a structural heart program, we are more and more involved into the shock as well, and we participate in the multidisciplinary discussion to see what's best for the patient. And then if there is presence of significant structural heart disease, then in that case we tend to favor a strategy of like using LAVA to stabilize the patient, get a plan, and see if the patient then can go for surgery or for transcatheter therapy. So a couple of words about this, since you alluded to that with the Impella for PCI, as you know, for the PROTECT trials. So actually, I got funding to do this prospectively, and I call it PROTECT Tower. So essentially, I'm doing this prospectively where I get patients with that have valvular cardiogenic shock. So they have severe aortic stenosis, either severe aortic stenosis or a degenerated bioprosthetic aortic valve with regurgitation or stenosis. If they're in shock, they will be placed on LAVA and then do the TAVR on LAVA ECMO support. Or if they have criteria or what I call complex high-risk TAVR, at risk for hemodynamic instability. There's all sorts of criteria. I'm not going to go over this right now, but essentially you have patients that require a complex TAVR and are at risk of going to shock during the case. So for example, you have to do double leaflet modification, and the baseline EF is like less than 35%, or pulmonary pressure like in the 60s or 70s. So this is a patient that I think it would benefit from it. If you are doing a complex TAVR, but the EF is completely preserved, then I think it will not qualify for this type of strategies. So we have started this now for a while. We are halfway there. The enrollment target was 30 patients, and we'll see what this looks like. So in conclusion, if you think you really need support, particularly for structural heart disease, go big, in my opinion. VA ECMO offers full cardiocirculatory support and oxygenation, but increased LV unloading and pulmonary congestion is bad in presence of severe AI. And LAVA offers full cardiocirculatory support, oxygenation, and unloading, and the underlying valvular lesion kind of becomes irrelevant, and then allows targeted intervention to the left side valvular lesion, again, because it's not on the way, for example, like an impact. All right, thank you.
No, this is great. it sounds like you guys have a great setup. I think around the country, a lot of places, CT surgery still controls ECMO, and they're obviously, open first and not very comfortable with transeptal puncture and stuff like that. And I know hospitals in my area where everything is basically by contract controlled by CT surgery, and they don't play well in the sandbox. So I think it makes perfect sense that the structuralists who are used to dealing with these biggest catheters, who are used to dealing transeptal puncture, would move into this space. I assume you have a very robust heart failure team as well who helps you, right?
Yeah, no, we work very closely in great collaboration, particularly with our cardiothoracic surgeons. They recognize it. I mean, sure, we leverage perfusionists, but everything that concerns percutaneous cannulation, I mean, that's what we do all day. we put large bar, we put big catheters, big sheets inside of arteries and vein safely, and then we can manage everything percutaneously from access to closure. So I think I think what you bring up, it's a problem in terms of adoption, because historically ECMO has always been under cardiothoracic surgery. It was invented by a surgeon, and he served cardiac surgery to become what it is. But like, as more and more our specialties are like colliding on many aspects, I think this is one of them.
Yeah, no, this is great. What do you do for your you put an antegrade sheath in the SFA to perfuse the leg?
Yeah, I usually do it. If it is for prevention, no, because I would expect that the patient is gonna get decannulated at the end of the case. I don't put an antegrade perfusion sheet in the case now. If it's for true shock that I don't know for how long the cannula is gonna stay in, I usually just do it.
I think part of the other place where it's good for people to have the skills and be prepared to do this is, when things hit the fan, you have to do this in a hurry. And, the classic example, I think, is when you have a valve drop in the ventricle. Those patients are going to get sick as hell, and you're not going to have a lot of time to dick around, and you'll sometimes the only way to keep them alive while you're trying to fix the problem is to put them on ECMO.
Yeah, no, that's an excellent point. I don't know if you guys are familiar, but like, now it's been like a year and a half ago or something. I had this crazy case where I embolized a valve in the left ventricle and I removed it transeptally. It's probably somewhere in Jackie-Tarashian. That patient was one of these cases. She came super sick with like a flail leaflet of a failed core valve, and I had to unicorn the other leaflet, and then so I put the patient on LAVA ECMO preemptively. I do the unicorn, no issues. I put the valve, embolizes, then I put the second valve, and the patient was rock stable during the entire case, despite there was a valve hanging in the LV because the patient was on LAVA. And then the same thing, I removed the valve on echo with the mitral valve like that was like wide open. The patient wake up, okay, no hypotension, no in the case, no AKI. I mean, if you're doing this complex stuff, you're playing with fire, and some of these patients have no reserve. You're preventing an intraprocedural death. You're preventing CPR on the table. The patient can go PA, anything can happen, but like, if you're on sport, then you have a safety net.
Yeah, well, it's like Bill O'Neill used to say that, if you're doing, high risk PCI, left main PCI, whatever, and you're doing it without Impella, you have to move very quickly. And if something goes wrong, you're screwed.
Yeah.
If you have Impella in place and the patient is stable, I never forget, I had a few years ago, I had a guy where I was doing left main PCI and his heart stopped, and he no pulsatility, heart silhouette is not moving. call the code, and everybody rushes in, and the patient looks at me and says, "Hey, what's going on?" And I was like, "Great, I guess the Impella is keeping you alive," and gave a bit of epi and came back, and we didn't need to start chest compressions, and
Yeah, that makes a lot of sense. So I mean, I trained at Henry Ford with Bill. So this is the stuff that he has been pioneering for many years. I think this is like as structural gets more and more complex, it's not just about implanting towers, and we do really complex cases both on the aortic and the mitral position. We need to have support. We are not going to be able to like remove leaflets completely, change valves, cut this, cut there in patients that have that to begin with, they start with very poor reserve. This is to me, this is the only way to do this safely.
yeah, no, I think that's critical. You don't want to take unnecessary risks. So if you can get maximum support, why not get maximum support? Do it safely, and then it's better to take it out afterwards than to need to put it in a hurry.
Exactly, and I mean, doesn't the cannula is at 15 or 17 French is not big. It takes you literally adds 10-15 minutes to your case. You put a bunch of pre-close and the cannula comes out at the end, and that's it.
Yeah, no, this is wonderful. Thank you for sharing. And as a community, we have to find a way to spread this around. And I think we'll have to train people, and you'll have to go out and preach the gospel.
Yeah, but like I really appreciate that you give me the opportunity to disseminate this. Obviously, I'm writing papers, I'm publishing cases, presenting, but the more the better. And ultimately, the ultimate judgment if something works or makes sense is the adoption, right? If people are not doing it, it's because they believe that it doesn't work. So we'll see.
This is great stuff. And to be honest, I may be not seeing quite as many patients in cardiogenic shock as you are. You obviously have a much larger catchment area. But I've used ECMO, and I've used even cardiopulmonary bypass for cases where I wanted to have no room for error. And I had a guy a couple of years ago who had no calcium whatsoever, wide open AI, and I wanted full control. And it made for a very, very stable deployment and no drama.
Yeah, that's another good one. When you expect to have like a very prolonged pacing to have like a perfect implant, like that's what you do. You put the patient support, stop the heart. It's like a normothermic peripheral cardiac arrest, and then put the valves where you have to.
Well, and I think that part of the message that needs to get out, and I think this is where the paradigm has to shift, is the classic teaching is ECMO does not work for aortic insufficiency, right? But that is because you're not draining the left atrium. So
Correct.
I think draining the left atrium makes all the difference. And I think, the guidelines need to change and the textbooks need to change for people to internalize that, because you hear this all the time. ECMO is not going to work in AI.
Yeah, and I mean, but regular ECMO, I agree, because
Right.
you're increasing further afterloading and make the AI worse. But if you're actively draining from the left chambers, essentially you're creating like a closed loop circuit of the same blood that you're recirculating. You have this. You should see how powerful there is. That case that I show with the double unicorn in the evolute, the patient is torrential AI, and the ventricular is pulse stack. Like is the ultimate like physiologic demonstration that like is getting actively unloading.
Yeah, no, this is great stuff.
Yeah, I think it's a good future.
Cool. Well, thank you for this. Thank you very much. And we'll disseminate this, and we look forward to hearing more from you.
All right. Thank you, man. Thank you for having me.
Awesome.